Hello?
Hello, Liang sisters, welcome, and you're ready to go.
Hi. Well, it's a pleasure for us to be here virtually. I don't know if you all remember, I'm Dr. Kim Liang, and I also have my twin sister, Kelly Liang. I'm a rheumatologist who's living with post-surgical hypoparathyroidism, and my sister Kelly is a nephrologist, and we're really honored to be here to speak with you today about basically labs, imaging, and tests for kidney stone monitoring. Okay, so we have no financial or other conflicts of interest, and just want to give the caveat that we're physicians, but obviously not endocrinologists like the other esteemed presenters here. Like I said, I've been living with hypopara since December of 2009, and so a lot of what I talk about here today will be based on my experiences both as a patient and a physician, mostly a patient perspective for a lot of about how to talk about the labs to your doctor and such, but also in terms of the lab work knowledge that is from my own experience as a physician as well. I also want to mention that, remember that every patient's case is unique, every physician is unique, every practice style is different. So, what we say here today, you still have to kind of just work closely with your own individual physician. So just a little outline. First, we'll go over why we need lab tests to monitor hypopara, what they are, how to read them, and then I'll turn it over to Dr. Kelly Liang for the urine studies and also testing like imaging for kidney stones. And then we'll finish up with just kind of how to discuss with your doctor and some other kind of lab tests that might be relevant when working up the symptoms of hypopara. So first, why is calcium and lab monitoring so important in hypoparathyroidism? As you've probably heard earlier today, normally PTH functions to keep the serum calcium and phosphorus levels steady on a continual basis. So when you lack PTH, that's going to lead to a decrease in serum calcium and an increase in serum phosphorus. And if the calcium by phosphorus product goes high, that's usually more than 55 in general, then you're going to be at increased risk of soft tissue calcifications, what we call calcinosis, and especially things like nephrocalcinosis, which can lead to renal failure. Now, that leads to talking about the urine so much later today, that if the 24-hour urine calcium goes high, like more than 300 milligrams, then you're going to be at an increased risk of forming kidney stones, nephrolithiasis, and the kidney failure from nephrocalcinosis. And if the calcium drops dangerously low, and that's usually anywhere around like less than 7.5 or so corrected calcium, that will increase the risk of tetany, seizures, and arrhythmias, and can be potentially life-threatening. So in hypopara, as we all know, calcium levels can drop very quickly because we don't have the ability to secrete the PTH to keep that calcium in tight balance. There's a lot of various triggers and stressors that can contribute to these fluctuating levels. Dietary changes over time can affect the total daily calcium needs. The 24-hour urine calcium levels may change over time. So even if you're good on one check, you still need to check it again over time. And phosphorus levels, if you have high phosphorus levels, then that may require a change in the diet to reduce phosphorus-rich foods. Potassium and magnesium are also important for calcium absorption. Low potassium, which is hypokalemia, and low magnesium or hypomagnesemia can also cause muscle cramps and weakness, which really mimic a lot of hypocalcemic symptoms. Vitamin D is very important for calcium absorption, for bone health, and also for immune health. We'll discuss this a little bit more later, but it's kind of a little controversial what the level should actually be, and also where we should keep it in hypopara. Now, remember that calcium levels don't always correlate perfectly with symptoms, so you may need possible additional tests and other workups sometimes, like don't always only assume that it's from the calcium levels. So in post-surgical hypopara, especially early on in the first 3 months post-op, it's extremely important to be monitoring these labs very closely because there is a possible outcome of a return of parathyroid function, meaning your parathyroid may just be stunned, quote unquote, and within 3 months it should return to normal and your hypocalcemia may become basically normal. So you need frequent checks to ensure that it's safe to wean down on the calcium supplements. Usually the surgeons, for some reason, use Tums all the time. But any calcium supplement that they put you on post-op, as you wean it down, you need to be having the regular calcium checks. And you need to watch for hypercalcemia as well. So, and then when you're a late or long-term hypopara patient after 6 to 12 months, then you're going to need regular checks to ensure that no dose changes are needed in the calcium supplements or the calcitriol doses, et cetera. And you're going to need the 24-hour urine calcium to monitor to reduce the long-term risk of kidney damage. So what kind of labs are the most important? See. So I usually think, on a lab slip, you should be having or asking for the serum calcium, albumin, phosphorus, creatinine. Early on, when you're like in the early post-op period, you should be monitoring the PTH to see if it's returning function. Ionized calcium is sometimes really helpful. We'll get into that in a little bit, but that's more like the actual calcium that kind of you don't need correction for. Potassium, magnesium, and then probably not as frequently, but periodically the vitamin D levels, like 25-hydroxyvitamin D, and perhaps the activated vitamin D level sometimes. And then if the creatinine level is high, or you basically have renal dysfunction already, then you may want to be checking BUN and other sort of renal labs. And then like sodium, if you're on hydrochlorothiazide, that medication can actually drop the sodium level sometimes. So kind of everyone always asks, like, how often should it be done? And there's sort of different monitoring intervals for every patient for each of the tests. And it really depends on how stable you are individually. And it changes over time. Within the first these are just general suggestions. Within the first 3 months post-op, I would say you should be getting these at least a calcium and albumin check every 1 to 2 weeks as you're tapering the calcium or trying to. And then if the calcium is low or you're feeling hypocalcemic, you should also be checking the PTH and phosphorus in conjunction with that. And you're following the PTH trends early on to see if it even is returning. And then you also want to check potassium, magnesium, and vitamin D and monitor these regularly if your calcium is low. Now, if you're permanent or long-term, which I feel like most of us are at this conference, basically, when you're having a medication adjustment, that's when it's really important to be checking things more frequently, like weekly or monthly. That would, again, be the calcium, albumin, phosphorus, creatinine. And if you're stable, these can be spaced out. If you're extremely stable, maybe twice a year even is okay. But that's if you're extremely stable and you haven't had dose adjustments for a very long time. And then if you're having symptoms and your labs are not correlating, then you should kind of check things again and maybe check the ionized calcium because that, again, especially for me and personally, I've found that correlates better with my symptoms. And then for the 24-hour urine calcium, if you're sort of 3 to 6 months out and you're sort of, again, a long-term hypopara patient, you should be asking for that to be done. And again, that's going to vary whether if it's abnormal, probably every 3 to 6 months for the first couple of years or until things are stable. And then, if everything's stable and your urine calcium isn't high anymore, you haven't had kidney stones, then maybe yearly would be sort of the maximum interval, I'd say. In some states, you can get this basic metabolic panel. I think Dr. Kohlmeyer mentioned this. Remember, it does include all the electrolytes, but it does not include the albumin on the basic metabolic panel, and also it does not include the magnesium and phosphorus. So those would have to be ordered separately. If you order a complete metabolic panel, that will include the albumin, but you'd still have to order magnesium and phosphorus separately. And then vitamin D levels should usually be checked every 6 to 12 months, especially if it's low. If it's low, it's going to be replaced most likely, and you'll be checking it 6 to 12 weeks after replacement. So just again, realize that calcium levels fluctuate throughout every single day, really every minute. But you, like, when should you check it? Like, what time of day should you check it? I think ideally you should check the calcium levels in the morning before you supplements to see kind of, or at least to me, that would be like, quote, the lowest, the lowest level of the day is before you start taking all your supplements, etc. But, is that practical depending on your job, your feasibility of doing it? It may not be practical, but just remember that if you take your calcium vitamin D supplements before measuring something like a PTH level, for instance, then if you took it right before, that may actually also, suppress the PTH level. And consistency in the timing of lab checks is key. So if you check it at a regular time, like you always check your labs at this given time, that would be helpful to compare from one lab check to the next. And then PTH levels in the immediate post-op period may be useful. There was a study that showed that those with low but detectable PTH levels in the immediate post-op period had a higher rate of parathyroid recovery compared to those with undetectable PTH levels. And then, of course, like I said, following the PTH levels in the immediate post-op period is really helpful. Now, just a little bit on how to read them. And I think we've probably gone over this before. We don't have to go over it too much more, but just remember that the reference ranges will vary between labs. So a given level, you have to look at it relative to that specific lab. Those are just some examples from Quest labs. And then same with basically all the different labs I mentioned, they're going to have their own specific reference range depending on what lab you got them checked at. So the most important thing, I think, in terms of for the serum calcium, you do have to remember you have to correct it for the albumin. So, and this goes whether the albumin is higher than 4.0 or lower than 4.0. I mean, I think a lot of times doctors only do this when the albumin is less than 4.0. But I mean, a lot of us are, especially if you're post-surgical, from thyroid cancer, for instance, you're somewhat young when this starts, and your albumin may not be low. It's going to be greater than 4 a lot of times and so basically, if your albumin is greater than 4.0, the corrected calcium is going to be lower than it actually appears. And if your albumin is less than 4.0, the corrected calcium is actually higher than what it appears on the lab. And it's based on this formula that I have up there that you plug it in. Just give an example here, so this is from myself. I had an albumin of 4.5. My serum calcium was 8.9. It was reading as 8.9. The corrected calcium, when you plug in the numbers into that equation that I said, my corrected calcium is actually 8.5, which is mildly low according to the reference range for that lab. So 8.9 sounded like it was so good, but 8.5 was, actually I was feeling kind of low. And then if your albumin is 3.5, which is a little bit, on the low side of albumin, then as calcium 8.5 actually corrects up to 8.9. So actually, then that's in actuality, your actual calcium level is in the normal range. So obviously, putting numbers into the equation is kind of complicated. So we have this. You can just kind of Google all the time any calcium albumin correction. Just type that into Google, and this is just an example of one. There's many different ones where you just plug in your actual calcium from your lab and your albumin level, and they'll tell you what your corrected calcium is. And that's what we should always be talking about when we say, quote, calcium levels. It's the corrected calcium levels. Now, there is this ionized calcium, which is basically, it doesn't need a correction factor per se. Like it doesn't you to, look at what your albumin level is or whatever. It's kind of how much actual calcium you have available to your tissues. The reason sometimes some doctors don't always order is because the handling is you need special handling. It's not always possible at all outpatient labs. It's a little more expensive. But I have found myself that Quest actually is pretty reliable on this. If you go to Quest labs, hospital labs are always reliable with it. It comes back with one of the very first things. It's automatically run almost like a stat lab. It's very quick turnaround, so it's going to be the first thing back. I think it's very helpful, if you're having symptoms that don't seem to correlate, even with your corrected calcium levels. So kind of when you're looking at how to interpret or read them in hypopara, if you're not really sure, like, are you hypopara, you're trying to figure out your post-op, you look for these expected abnormalities in the disease. Is that you're going to have a low serum calcium corrected, you're going to have a high serum phosphorus, and then low or low normal PTH level. And if you're long-term and if you've had high urine calciums, you might have elevated creatinine that would indicate kidney dysfunction, which is not good. And then if you have a high serum calcium level, but a low PTH, that could mean either that you're taking excessive amounts of calcium supplements, but you are still hypopara, but you're just taking a lot of calcium supplements, it's gone high, or that perhaps, the PTH might just be low because of the high serum calcium level. So this gets a little tricky when you're immediate post-op, because you're trying to figure out whether your PTH is recovering. And if you're taking too much calcium for what you actually need, that may lead to a continually suppressed PTH, and you sort of have to see as you wean it what kind of happens. If you have elevated creatinine level, like kidney dysfunction, then you're going to need the full BMP, I would say. Kidney doctors always like to see the entire thing. Kidney dysfunction itself can cause hyperkalemia, high potassium, and itself leads to high phosphorus. And then in the BMP, you're going to see whether your potassium or magnesium are low, whether you need to replace with supplements with those. Because again, hypokalemia and hypomagnesemia, it can cause muscle cramps and weakness, very similar to hypocalcemia. And vitamin D, just a little thing on this that, I think I actually just showed a slide that said the Institute of Medicine says that, greater than 20 is, quote, okay, but I think we all agree that the 25 hydroxyvitamin D ideally should be over 30. That's what's considered more optimal or sufficient. I think people who have some immune dysfunction, I'm a rheumatologist, so I take care of a lot of people with autoimmune and immune issues. And I think, there are a lot of times they'll do better if it's 40 to 60. A lot of people with fibromyalgia also feel better when it's 40 to 60. And again, you don't want to go too high, of course, on it, though, because then that can lead to hypercalcemia. The 125 dihydroxyvitamin D is the activated form of vitamin D. It's the form that is calcitriol. That's the form that's needed for calcium absorption from the gut. PTH is needed to convert the 25 hydroxyvitamin D or parent vitamin D to the 125 dihydroxy, the activated form. And so if you're hypopara and you're on calcitriol, this becomes sort of very difficult to interpret, because it's going to depend on how recently you took your calcitriol. You may sort of just be measuring your calcitriol dose in a sense. So I think it's not generally checked. But I think, if you're having, for instance, I don't know, like high calcium and you're not really sure why, and, it might be worth checking this as well. I did mention hydrochlorothiazide. There's a blood pressure medication that's used to help lower the urine calcium level in hypopara patients. And potassium can go low from this medication. It's just a side effect, basically, of the medication. So you may have to replace the potassium, either take potassium supplements or eat potassium-rich foods to help combat this. Or you may, like me, go on to a combination. And there's a triamterene hydrochlorothiazide, which is called diazide, that can help that help bring up the potassium level down. And then other potential side effects of hydrochlorothiazide include, like, it can actually, cause high calcium in normal people. For hypopara patients, I don't think it ever caused out true high calcium, but it will help with the calcium reabsorption from the kidney, so it decreases the urine calcium level. Like I said, it can cause low sodium. It can sometimes cause low magnesium. Actually, it can increase the uric acid level, so it might increase your risk of gout to some degree. Okay, and then I think I'll pass it over to my sister now, the nephrologist, to talk about the urine test and imaging for kidney stones. So. Okay. Hi, so I'm happy to just go over some of the urine tests and imaging that we would recommend to either look for or monitor people who have kidney stones or who are at risk for kidney stones. So what urine studies should you monitor? Well, first of all, as my sister mentioned, one of the main things is the 24-hour urine calcium and creatinine. It's very important to know and monitor periodically in long-term hypoparathyroidism, especially if you've never done it before and or you're still with symptoms despite calcium levels that are at goal. Reference ranges vary by labs, but for example, reference ranges from the Mayo lab suggest that a 24-hour urine calcium should be between 20 to 275 milligrams for females and 25 to 300 milligrams for males. Ideally, you want to keep that urine calcium level less than 300, and actually even less than 250 for the most part. Sometimes we'll accept up to 400 milligrams, but that's kind of pushing it in order to prevent the risk of kidney damage or kidney stones. The main recommendation that I always make to all patients who are at risk for kidney stones is to just keep really well hydrated. So I recommend drinking at least 2 to 2.5 liters of fluids per day. And a good rule of thumb is that when you look at your urine color, it should be very light to clear in color. If it's becoming sort of darker yellow, it's basically an indication that you're not drinking enough. So you want to just keep drinking, if you see it getting darker. In certain situations, for example, in hypomagnesemia, checking a urine magnesium may also be helpful. So other urine studies we get oftentimes is a simple urinalysis, and that gives us sort of a crude estimate that whether or not you have blood in the urine or certain crystals that can be picked up. If you have kidney dysfunction with an elevated creatinine, we'll also oftentimes order a urine protein to creatinine ratio, which is basically a crude estimate of how much protein is in the urine, or a 24-hour urine protein, which is sort of a more accurate measurement of that. If you have a history of kidney stones, I always usually recommend getting a formal 24-hour urine supersaturation analysis, which is also called a litholink study. And it's also just a 24-hour urine collection, but it's usually done by a special company called Litholink, where they actually do a whole slew of different chemistries that give us information about what kinds of kidney stones you're at risk for, and helps guide me as a nephrologist as to what we can do to help you prevent further kidney stones. So this is just a table that shows kind of a breakdown of all the different kinds of kidney stones, or like the main types of kidney can get. Calcium oxalate kind of leads the list there. It's actually the most common type of kidney stones, and then followed by calcium phosphate stones. There's also uric acid stones, struvite stones, and cystine stones. Uric acid stones are often people who have like a history of gout, for instance. Struvite stones are oftentimes people who get UTIs, like urinary tract infections, kind of cause these struvite stones, usually from a bacteria, special bacteria lead to that kind of stone. And then cystine stones is almost like a genetic form of kidney stones. People will often have a family history of stones if you have that type. It's very rare. So in hypoparathyroidism, the main kind of kidney stones we worry about is the calcium-based stones, obviously. So calcium oxalate, as I mentioned, is the most common. These are stones that actually form in acidic urine. So acidic urine is like low pH, low urine pH, meaning around 4.5 to 5.5. You also get an increased risk of these stones if you have low citrate levels in the urine or hypocitraturia. Calcium phosphate stones is the other major type of calcium stones. These form in basic urine or high urine pH, typically greater than a pH of 6. These can be classified as either bruchite stones. These are really hard, brittle stones that are not easily treated by lithotripsy. Hydroxyapatite stones. Hydroxyapatite is actually the same crystal phase that you see in bone. And then calcium carbonate phosphate. So if you see, like, for instance, if you have a stone and they analyze it and they list it as either bruchite or hydroxyapatite or calcium carbonate stones, like these are all classified as calcium phosphate stones. And this is a little picture of what a calcium oxalate stone might look like. As I mentioned, the most preventable cause is dehydration and low urine output. But other factors can also increase a person's risk for calcium oxalate stones, including a high sodium diet or high oxalate intake or high protein intake. So general recommendations to prevent calcium oxalate stones are not only drinking lots and lots of fluid, but also kind of limiting your salt, protein, and oxalate intake. So these comprise 60 to 80% of all kidney stones. So if you don't know what kind of stone you make, this is probably the kind most likely you're making. And then these are examples of calcium phosphate stones. As you can see, there's a whole bunch of different kinds. They all look a little different. And then here are crystals that I wanted to show you in the urinalysis. So if you give me a random urine sample, I can look at it under a microscope and see whether or not you're forming these crystals. And this also gives me an idea of, what kind of stones you might be prone to making. So if your urine shows crystals like on the left-hand side, these are calcium oxalate crystals. We call them like envelope shaped. And then on the right-hand side, the calcium phosphate crystals kind of look like almost needle shaped or large flat shaped plates or wedge shaped prisms. So moving on, like what kind of imaging do I need to look for kidney stones? Well, first of all, we can get a kidney ultrasound that provides detailed views of the kidneys and is actually the safest kind of imaging study to get because there's no radiation exposure at all and it's very non-invasive. It looks for hydronephrosis, which is swelling of the kidney due to obstruction due to stones. And then it can actually pick up on actual kidney stones and calcifications in the kidneys. And also we assess for kidney sizes, whether there's cysts in the kidneys. We also look at the density of the renal parenchyma and cortical thinning. These are things that, if you have reduced kidney function, these things might be abnormal as well. You can also look at a CT scan, especially if you have kidney stones. A CT abdomen and pelvis without contrast is kind of what we would recommend. It provides evidence of kidney stones along the entire urinary tract, meaning the kidneys all the way down, including the ureters and the bladder, to see if there's any stones along the entire urinary tract. It is the most sensitive test for detecting kidney stones, approximately 95% sensitivity, and can detect as small as 3 millimeter stones on that kind of scan. Sometimes we'll get an abdominal X-ray, like oftentimes we can start with an abdominal X-ray or a KUB, only really reveal calcium kidney stones, but not other types such as the uric acid stones I mentioned. So here's an example of a stone that we see on an ultrasound. It'll look sort of more bright white on it with shadowing behind it. And then here are examples of what stones would look like on a CT scan. They're also, as you see, the arrows are pointing to these bright white like calcifications. These happen to be, within the urinary tract, not even in the kidneys per se. And then here are how stones might look on an X-ray. So like, as I mentioned, these would be calcium-based stones that you can pick up on X-ray, and they're also like the white little tiny stones that you see on both sides there. So what imaging is preferred for kidney stones? I kind of touched on it, but initial screening for kidney stones, if your urine calcium is high, might start with an abdominal X-ray or a kidney ultrasound because they're the easiest, cheapest, and sort of simple and safe to do. If you're symptomatic though, and you have like flank pain or back pain that is just excruciating and there's a high suspicion for kidney stones, that might be a time that we actually just start with a CT abdomen and pelvis without contrast. Also, if you have high stone burden or recurrent kidney stones, we oftentimes can even just monitor with a CT abdomen and pelvis because that immediately tells us is there kidney stones in the kidneys and along the entire tract. And generally, I recommend monitoring every 1 to 5 years. If you have active stone disease, I'll check it usually even more often than that, like every 6 months, like if you're an active stone former. So the last thing I sort of wanted to talk about is a 24-hour urine supersaturation test. And what exactly is this? So it measures a panel of chemistries in the urine that are important in kidney stone formation. As I mentioned, the most common form is the litholink test. It assesses for risk factors for calcium oxalate versus calcium phosphate versus uric acid stones. And on this panel, it basically gives information on whether or not you have a high risk for calcium oxalate stones. And that would be if your results show a low urine pH, like less than 5.5, a high supersaturation for calcium oxalate, a high urine calcium level. As I mentioned, on the litholink tests, they say that greater than 200 for females or greater than 250 for males is actually considered high or a higher risk. And then hypocyturia. If you have results that show the following, you'll have an increased risk for calcium phosphate stones. These would be high urine pH, greater than 6.0, high supersaturation for calcium phosphate, a high urine calcium again, or high urine phosphorus. So how often do I need to do a urine supersaturation test? Well, basically, if you have no kidney stones ever and you've never had any, no one in your family even has any, you may never need to do it. However, if you do have like even just one episode of kidney stones, or especially if you have a second episode, I generally recommend doing this test at least once, and then you may want to repeat it yearly, just to make sure that you're kind of doing well on your fluid intake and your preventative measures. And then if you're an active stone former with multiple stones or more than 2 episodes, you may need to repeat this every 6 months or even more frequently if you're changing therapy. So if you're somebody who, your nephrologist has put you on Uracit K, for instance, you may need to be checking this even every 3 months, if you're making changes in that Uracit K dose. So this is just a list of the urine litholink test parameters that actually is included in the test. It gives you the total volume that you made, the calcium, creatinine, citrate, phosphorus, pH, sodium, urea nitrogen, the actual oxalate level, chloride, ammonium, magnesium, potassium, uric acid, sulfate, and then it gives you a cystine screen, and then saturation calculations for the most common kidney stone types, which would be the calcium oxalate, calcium phosphate, and uric acid. So I would say that the supersaturation calculation is kind of a nice perk for the litholink study in particular, because sometimes you can have like a normal uric acid or a normal phosphate level, even calcium level in the urine. But if you have a high supersaturation for that type of stone, that's kind of even more important actually than just the actual, say urine calcium alone. So the process of doing a 24-hour urine litholink test is that basically your doctor will order it, and then the company will actually send you a urine collection kit to do at home. You view or read the instructions on a proper collection method. I've included a link here for the actual video that they give. It's pretty straightforward. I've never had patients say that they didn't understand how to do it. And then you send the urine sample back to litholink by mail. And now I'm going to send it back to my sister to finish up about how to discuss these tests with your doctor. So like I said before earlier in the talk, that there are different, practice styles of different doctors, different endocrinologists, and certainly different experience levels of endos with hypopara specifically. Also depends how your doctor speaks to you. They may use more medical language versus less medical language. If you understand a lot of medical language, I guess I would encourage you to, let your doctor know they can actually talk in a more sophisticated manner with you. And then to me, the biggest thing is, are they sort of rigid algorithm type people, or are they more going to be more flexible in working with you, considering you know your body the best? Your body's constantly in flux with living with hypopara, and are they going to engage your patient preferences? Of course, I think this latter is the better way to go. Find a doctor who can work with you. Don't be afraid to ask questions. They shouldn't make you afraid to ask questions. You shouldn't feel that way in your appointment. If you're uncomfortable, you should consider second or third opinions, especially with endocrinologists who have more experience with hypopara. However, I will give a caveat as a doctor myself that I don't think you should give up after one visit. I think you should at least probably give a doctor a chance of two visits at least, to kind of get that sense of like, maybe on that first visit, they were just really preoccupied with trying to gather your history. Depending on how much history you have, it can be overwhelming. They may be time crunched, whatever else is going on that given day. And so if the next visit and you're following up and, you just get a better sense if you can click or not, right? Doctor shopping, like if you go to too many doctors, that doctor will see, oh, you've been to like 3 other people. And, then that doctor might think, well, this patient is just completely too hard to please. She's going to be, quote, high maintenance and things like that. So just be careful in terms of how many opinions you get. But at the same time, I do think, especially with this rare disease, that it's worth considering if you're not comfortable with your current endocrinologist. I'll just share that I did, of course, go to a second endocrinologist who's a hyperparathyroid expert after my initial one. I wasn't happy with. So, I mean, that's me as a doctor, So, and then you should establish what kind of is going to be your acceptable goal calcium level. I think that's probably one of the most important things in discussing what's going on, what you're going to do, how you're doing, quote unquote, because, there's this quote ideal goal calcium level, which if you're not on PTH replacement, I mean, that para's off, is not easy to get anymore by and large. And so if you're just on the standard, calcium calcitriol, they're going to say your goal level is something like 8.0 to 8.5, quote, low, normal, or mildly low. That's kind of because they want to help protect your kidneys and, they want to have urine calcium be less than 300, and keeping your calcium in the, quote, low normal range oftentimes allows that balance. But if you're having too many symptoms, as I did, as a lot of us do, I think, at that sort of low normal level, you have to balance that with what is your actual 24-hour urine calcium level. If your 24-hour urine calcium level is okay, less than 300, maybe you can go ahead and push the supplements, et cetera, to let your goal calcium, serum calcium ride higher. If your urine calcium is more than 300, then, kind of maybe there are other things you can do to help get it down, like hydrochlorothiazide, et cetera. And I think I definitely agree with whoever said in the audience and earlier that a fair number of hyperparathyroid patients, especially post-op hyperparathyroid patients, will feel better when their calcium level is where they were pre-op, right? Like, so it's going to be higher than 8 to 8.5 because that's not actually a normal person before they went for surgery. That's not usually where they sat. They usually sat around 9, 9.5, et cetera. So, and that's kind of what I just said there. And then you should discuss your symptoms with the doctor, before talking about lab work. I think it should be really important to share with your doctor what kind of symptoms you're having. They may be hypo or hypercalcemic symptoms. You can see here that a lot of them overlap. Usually like the tingling, the paresthesias, the numbness, muscle twitching, those are going to be hypocalcemic symptoms. Fatigue and feeling weak is going to be, you don't know, like, is that hyper or hypo? If you're feeling nauseous, vomiting, constipation, that's usually hyper. If you're feeling brain fog, like bone pain, that is probably hyper, but brain fog can also occur with hypo. So a lot of times the symptoms don't tell you completely, but at least they'll know kind of what you might be experiencing more likely. And like I said, I think you'll want to talk, if you're feeling hypocalcemic, you'll want to ask the doctor kind of, can you take extra supplement doses, extra calcium? If so, how many, how often, and how long? What about the calcitriol? Like if you're on a given calcitriol dose, should that be increased? Could you take an extra calcitriol dose or not? Calcitriol is very potent. Be careful. It can raise your calcium a lot more than just taking an extra calcium supplement. But if either of the above are permitted, then kind of the next question you need to remember to ask, because they might not automatically tell you, you have to ask, like, when should I next check my 24-hour urine calcium then? If we're going to increase these things and try to help me get out of hypercalcemic symptoms, when should I get my labs checked again? When should I get my 24-hour urine checked again? If the doctor is absolutely unwilling to hear you out and acknowledge that these symptoms are in fact hypocalcemic symptoms, regardless, depending on wherever your level is, that's again where like if you're hitting a wall, that's where sometimes you may consider a second opinion. You may consider going on off-label therapies at this point, like Futeo, like clinical trials, like the TransCon trial, et cetera. So obviously in the past, that would be the point to put people on NatPara, but NatPara is not readily available anymore. And then you kind of want to discuss and observe what things trigger hypocalcemic symptoms for you. When you're under sort of duress and things that trigger your symptoms, then sort of ask to have those labs ready to have to be checked, quote, as needed. And, usually that could be, even like weekly as needed or whatever. And for me, things like illnesses, infections, exercise is a huge one. It's really difficult to do heavy exercise anymore. Menses is a huge one. I think I've heard this from many women. Stress, whether it's physical or emotional, travel, for me, like time changes, even weather changes, I've heard for some people. I don't think it affects me as much, but these are all things that can trigger symptoms for people. And again, asking kind of, is it okay to take extra calcium for these events and how much, et cetera. When the hypocalcemia is really severe and it's an emergency, I think Dr. Kohlmeyer touched on this, so I won't go too much, but basically it's tetany, like full body. You yourself are not able to communicate at that point. You need to have that, quote, advocate or somebody helping you, taking you to the ER, et cetera. This includes seizures, arrhythmias, laryngospasm, all of these things. And this usually occurs when the calcium is severely low, again, usually less than 7.5, maybe even less than 7, and that's when you need the calcium level stat, you need the IV calcium infusion immediately, et cetera. If you know this has happened to you before and you know what your prodrome was, quote, something that you felt right before this happened, that is helpful to keep a track of and like communicate that with your loved one, your providers, et cetera, so that if that happens again, action can be taken even more quickly. So if you have serum phosphorus level being high, that's where dietary changes, and this is where sometimes even nephrologists are helpful just for this because they deal with this all the time in chronic renal disease patients. But basically, you want to get information on low phos diets, and there's even like phos binders. Again, these are in CKD, chronic kidney disease patients often take things like phos, Renagel. Sometimes these things are used in hypopara patients to help bring down the phosphorus level. PTH replacement therapies definitely lower serum phosphorus very well. So if you're able to get on one, like Futeo off-label, or if you're on the NatPara, SUP, et cetera, that'll help. I just listed some of those foods there that are high phos foods, so you want to avoid those to be on a low phos diet. And then it's important to keep the diet consistent with regard to calcium-containing foods. So like, your doctor may even ask you might want to share with your doctor, like, you always usually eat this many dairy products, et cetera. And so if I think for me, this is a thing when I'm on travels, I can't get dairy products as easily. And I think that's partly why I end up feeling more hypocalcemic, et cetera. On average, each dairy serving has about 250 to 300 milligrams of elemental calcium. So kind of you can think about that in your head, I guess, like if you're not eating your usual yogurt or whatever, then maybe it might be reasonable to take that extra little bit of calcium. So just finally, some other lab tests I do think is important to kind of mention here, because a lot of us, especially post-surgical hypopara patients, came into this because of thyroid. I know we always say hypoparathyroid is not the thyroid, but a lot of us do actually have hypothyroidism, either post-surgical induced or autoimmune, et cetera. And so these symptoms can also overlap. So hypothyroid symptoms include fatigue, weight gain, weakness, cold intolerance, dry skin, hair loss. And hyperthyroid symptoms would be like palpitations, anxiety, increased heart rate, but it can also cause fatigue. I think a lot of doctors assume that hyperthyroid, you're going to have increased energy, and that's just absolutely not true. I mean, I've been both ways, of course, with my TSH numbers, and when I'm hyper, I'm also feeling more fatigued and kind of just not right, feeling sort of weak and not myself. And then you'll also be sweaty and heat intolerance, increased bowel movements or diarrhea. It's unclear whether hypopara itself interacts with thyroid symptoms. I think a lot more studies are needed on this. Hopefully we'll hear more about it later in the conference. So you do want to get these thyroid labs checked, especially if you're post-surgical. So TSH, and then also the free T4 and free T3. The TSH is the most sensitive marker that shows kind of, if the TSH is low, then you're relatively hyperthyroid. If your TSH is high, that's like you're hypothyroid. This is like the first thing. And then free T4 and free T3 are important to see kind of, if they correlate with where the TSH is sitting. And the free T4 and free T3 are probably a little harder to interpret because they probably fluctuate more depending on when you actually took your last thyroid dose. So I know sometimes people aren't checking this, or the free T4 only gets reflexed if the TSH is abnormal, but I like to have all three checked. I ask for those. If you have any question about autoimmune thyroid disease, you could get the thyroid antibodies like the TPO and thyroglobulin antibodies checked. If you're a thyroid cancer patient like myself, you will want to be monitoring your thyroglobulin and the thyroglobulin antibodies on a regular basis because they are actually sort of disease markers for the thyroid cancer. Now, as a rheumatologist, as you can imagine, I get a lot of consults just for fatigue or feeling weak, muscle weakness, and these are symptoms that happen in hypoparathyroidism. And so if you have any family history of autoimmune disease, or you do have some question of an autoimmune or rheumatologic disorder, the basic labs you'd want from that standpoint are actually muscle enzymes, CK and aldolase. That as a first pass will tell you whether you have sort of inflammation in your muscles. If they're normal, it's very unlikely that you have inflammation in your muscles. Same with SED rate and CRP. These are inflammatory markers. They're very non-specific though, but you could ask for those. Vitamin B12. So vitamin B12 deficiency can also cause numbness, tingling, paresthesias, fatigue. So I think that's important to rule out in everyone. The vitamin D, we've kind of talked about that. And then iron studies, if you're a woman, heavy menses oftentimes causes iron deficiency. That will cause fatigue. And the CBC, of course, to rule out the anemia. And then just finally, of course, I can't help but talk about this as a rheumatologist. Fibromyalgia syndrome, like, do hypopara patients have fibro? Is fibro just, part of being hypopara? Is it, can you just have both? I think you can just have both. Fibro is extremely common, and it's going to kind of mimic a lot of the hypopara symptoms. And it's again, quite common in women, young, middle-aged women. It's a syndrome of widespread pain, a lot of times muscle pain, fatigue, poor and unrefreshing sleep. And then on exam, it's actually very easy to diagnose. It's like you just have a certain number of soft tissue tender points on exam. One thing I always like to ask patients is like when someone presses you or say your cat, gets on you, does it feel like it leaves a really prolonged bruise? It's really painful. And that kind of a thing is sort of, that's what we hear in fibro. There's no one lab test that's diagnostic with fibro. Actually, labs are served to exclude other diagnoses. By definition, they usually are normal. And primary care physicians can manage this just as well as any rheumatologist. If you have a lot of accompanying conditions like migraines, irritable bowel syndrome, anxiety, depression, TMJ syndrome, that oftentimes will correlate with having fibro. And then to treat this, you often do like a low impact aerobic exercise program. Things like gabapentin, Lyrica, Cymbalta, Savella can be used to treat it. So, and again, these are just tender points that people usually, will press on when they're examining you to help diagnose the fibro. So just in conclusion, we want to impress upon you that monitoring calcium levels regularly is very important in hypoparathyroidism. When measuring the calcium levels, you want to correct for the albumin level and or measure the ionized calcium level. It's also important to remember to check your phosphorus if you're immediately post-op, the PTH, also the creatinine, potassium, and magnesium. The 24-hour urine calcium should be kept less than 300 to 400 milligrams to prevent long-term kidney damage. And when you discuss your lab results with a doctor, include a discussion of your symptoms and goals, as well as your long-term risks based on the results. And you may want to consider other labs to rule out thyroid or other contributions to muscle weakness and fatigue symptoms. I do want to acknowledge Dr. Bart Clark and Michelle West, who've been instrumental in this talk in the past. So,
all right. Let's give it up for the Liang sisters. Thank you. All right, Kelly and Kim, if I could have you guys kind of scooch together so we can put you up on the screen and ask some questions. Hey, there they are.
Hi.
Everybody's waving to you. All right, so who has questions out there? Where's Michelle?
Okay, I'll start with one from our virtual audience. Will kidney stones cause permanent kidney damage or failure if left untreated?
Well, they have the potential to, like if it gets blocked. So that's where the imaging becomes really important. If they're just sitting in the kidneys and they're like really small, they don't by themselves cause kidney failure.
Anybody in the room have questions? Bob?
When you do a 24-hour litho panel.
Let's get your microphone there real quick.
Hi, I'm John. When you do a 24-hour litholink panel, as a hypopara person, do you interpret that differently than the general public? I mean, how would you adjust for being hypopara?
Yeah, I mean, the interpretation isn't really different from the general population, but kind of thinking about balancing that actual urine calcium level with your symptoms, as my sister talked about, is probably where the management becomes a little different. So if we have to accept, for instance, a urine calcium that's a little higher than like the 200 or 250 in order to keep your symptoms controlled and to keep your serum calcium levels adequate, then we might do that, especially if your kidney stones aren't like a major issue. So I might be a little bit more strict in terms of where I keep those urine calcium levels in a hypopara patient, in a non-hypopara patient compared to somebody who is hypopara. So.
Thank you. That was great. I just can't believe you're twins and you know so much about this. This is fantastic. We're all going to be asking you. So we learned that in ADH1, 47% of patients have kidney complications with normal urine calcium, which to me is surprising. So do we know that? I mean, I know when we follow surgical hypopara patients long term, we know how frequent the kidney problems are. But what would be your explanation why it would hurt the kidney if the kidney's not spilling a lot of calcium?
Yeah, but do you know if like the serum calcium levels are high or low or normal?
No, so this would be surgical hypopara patients with fluctuating calciums, like we all know, but without a urine calcium over, let's say, 250 milligrams, should we still worry about kidney problems? I mean, I would think that's the etiology of why it happens. We shouldn't worry as much. But what I'm being taught and what I've learned in the past is we still worry, which is why they need why we need parathyroid hormone replacement. But what would be the other explanation? Why would it hurt the kidney if the kidney's not spilling calcium, I guess is my question.
Yeah, well, anytime that you're hypercalcemic, that can cause like volume depletion and basically cause kidney damage and kidney failure in a sense, like hypercalcemia. So if you're having
overtreating by mistake, that makes sense.
Right. Like if you're sort of intermittently overtreating with hypercalcemia during large portions of your life, for instance, getting dehydrated because of intermittent episodes of hypercalcemia, I can foresee that as causing kidney damage even without like 24-hour urine calciums being abnormal at all. I don't think that.
Would you be okay with me letting my patient's calcium, let's say, be 9.4, like some people really like, if their urine calcium's less than 300? And should I do 24-hour urine on those patients more frequently to make sure I'm not hurting their kidney without knowing it?
Yeah, I mean, I think that would be reasonable, like if the 24-hour urine calcium is less than 300 and the serum calcium is like 9.4, that's still within normal, so I would accept something like that. It's when the serum calcium gets actually higher than normal that we start to worry that by itself can cause kidney damage. It by itself can cause kidney failure, to run the calcium levels in the blood too high. So that example that you gave sounds like a reasonable sort of balance, if somebody is sort of running that kind of urine calcium being low enough, but keeping their serum calcium higher than, that 8.5 range that, the guidelines might suggest. I don't think that by itself would be, dangerous for the kidneys per se. But you just have to kind of monitor things over time and make sure that you're not accidentally, going over like 10.5 or whatever, sometimes.
Okay, Michelle, you have one more?
Yes. How much can what a person eats within 24 to 48 hours before their blood and urine tests impact the results?
Well, I think from the serum calcium standpoint, like it can affect it quite a bit. Like I think if you just took your calcium, and you went to the lab, within a couple hours after that, you're going to have to take that into account. Even like dairy products, like if you just eaten a high dairy thing. So I think it can affect the serum calcium quite a bit. And then for the urine, I think the urine ones are more long-term, kind of reflects your diet over time. I don't think you can change it that much just in that one day, for instance. It kind of is more reflective of what you've been doing, that being said, like I don't generally recommend doing like a litholink study, for instance, in the hospital when you like not eating your usual diet, for instance. So I mean, it can affect it to an extent, but I think it's more reflective of just kind of overall what kind of calcium levels you've been running and how much calcium you're spilling in the urine over time.
Okay, and then we have one more in the room, and then we'll have to call it.
I'm just wondering, because one of you's a rheumatologist and one of you's a kidney doctor. I have chronic kidney disease and I have autoimmune disease and I'm post-surgical. I have a big problem getting my doctors to communicate with each other, no matter how hard I try or what information I give. Any advice?
Yeah, that's a really, really great question, actually, because it's relevant to so much of medical care in general. I think as a patient, you should just point blank ask your doctor to, call or, talk to the other doctor, whatever, and get back to you, so-called, on what was the upshot of that conversation. Because if you sort of ask for that to be done and then that's sort of on their to-do list that they have to do it, then it'll get done. If it's not something that is a thing that you specifically asked for, then what happens as a doctor is that you are super busy. You finish your clinic, then you do your notes. That is an extremely long day. By the time you're done doing your note, of course, it's not time. You will not be talking to another doctor. That's way after hours. You don't even know if they're awake. So then all you do is you send your note to them. Like you just say send the note to them, and then your secretary may send that note or not. I mean, you don't know when that's going to happen. If it happens, sometimes glitches happen, and then you never know if that communication ever happened. So I think if you sort of ask your doctor to communicate, kind of say, I'd really like if you could talk to my nephrologist or whoever, or my rheumatologist, and have that conversation happen, and then either in a couple of weeks, do you mind if I check back to see what you found out, or at least by the next visit, can we discuss what you all what was your conclusion after talking? Just kind of point blank ask it. I don't know if you have any other thoughts. How did you? I think that that is a common problem, and like she said, and I think that just actually asking each of those, your nephrologist and your rheumatologist, each of them, to don't even just trust like, okay, well, I asked my rheumatologist to, ask your nephrologist then to also reach out to the rheumatologist. And then if you have both of them, hearing your wishes, then at least one of them hopefully, will come through and you'll get some connection between them. And then if you do have the ability to send messages through like an online portal or something, you can easily just within a week or so just message either or both of them asking, so did you get a chance to talk to the other doctor, and what did you decide? Do you agree on the plan? And that usually works. Yeah, I've actually had some patients do that where they send me the same exact portal message that they sent, say, their pulmonologist, or they want to know the same question from both perspectives, right? And they literally send the exact same message to both, and then I can see in the portal what did the lung doctor write back to her? That's helpful for me, and so that's kind of a nice way to kind of communicate without making the doctors find the time to somehow connect by phone. I don't know if that's helpful.
All right. Thank you, ladies, so much. It's so great to see you. Thanks for your presentation today.
Thank you. Thanks. Nice to see you. Thank you.
Okay, so